Good morning, everyone. Today we're going to talk about one of the most important foundations in orthodontics: how we diagnose and plan treatment. Many of you may think orthodontics is just about straightening teeth or getting the molars into a perfect class-I relationship. But in reality, modern orthodontics is much broader. It involves understanding not just the teeth and the bite, but also the face, the soft tissues, the smile, and even the psychological well-being of the patient. So, in this lecture, we'll explore why we treat, what goals we aim for, the role of the orthodontist in facial aesthetics, the kinds of records we need, how to analyze facial symmetry and proportions, and how treatment planning today begins with the face, not just the occlusion. We'll also look at optimization, meaning how to fix problems without losing what is already good about a patient's appearance. By the end, you should see orthodontics not just as tooth movement, but as the science and art of facial balance. Why we treat. The first question is simple: why do we treat orthodontic problems? Traditionally, orthodontics focused on correcting malocclusion, aligning the teeth, creating functional bites, preventing relapse. That was the classic model. But today, we also focus on aesthetics and quality of life. Think of a teenager with very protrusive incisors. Functionally, he might be able to chew fine. But psychologically, he may be embarrassed to smile or teased by peers. Treating this case does not just improve the occlusion, it transforms his confidence and self-image. So modern orthodontics serves multiple purposes, improving function, health, aesthetics, and overall well-being. The orthodontist's role in facial aesthetics. Now, what role do we play in overall facial aesthetics? For children and adolescents, we have the advantage of growth. By using growth modification appliances, we can redirect skeletal growth to correct discrepancies. For adults, growth is complete, so we often need to combine orthodontics with surgery to correct severe skeletal problems. But perhaps the most important responsibility is preserving what is already good in the patient's face. Imagine a patient with a gummy smile, but attractive cheekbones and lip support. If we only focus on retracting teeth mechanically, we might flatten the profile and lose what makes the face attractive. Instead, we should plan surgical impaction of the maxilla to reduce gum display while keeping the good features. This shows you that orthodontists are really architects of the face. We don't just move teeth, we shape faces. Records and documentation. Good treatment planning starts with records. These are our diagnostic tools. We use facial photographs in standard positions: frontal at rest, frontal smiling, profile, and oblique. But we also now use video, because a smile is dynamic, not static. Watching how the lips move over the teeth during speech and smiling gives us more information than a frozen photograph. Intraoral photographs are also essential. We take 5 standard shots: the frontal, the right and left lateral views, and the upper and lower occlusal views. Black background close-ups help highlight small aesthetic details like incisal edges and gingival contours. Cephalometric radiographs remain important for skeletal analysis. But we must not treat numbers in isolation. Sometimes a ceph analysis might suggest extractions, while clinically, the soft tissues would be harmed by such a plan. Aesthetics should always be the final guide. Finally, digital imaging and visualized treatment objectives, or VTOs, have become very powerful. They allow us to simulate surgical or orthodontic outcomes and show them to the patient. This helps us refine our planning and also improves communication with patients and families. Clinical examination of facial symmetry and proportions. Beyond records, we must learn to examine the face carefully. First is the vertical analysis. We divide the face into 3 equal parts: the upper third from the hairline to the glabella, the middle third from the glabella to the subnasal, and the lower third from the subnasal to the menton. If the lower third is too long, this may indicate vertical maxillary excess, often seen with a gummy smile. If it is too short, it may indicate deep bite tendencies and vertical deficiency. Next is the transverse analysis, also called the rule of fifths. We divide the face vertically into 5 equal parts, each approximately the width of one eye. If the central fifth is narrow, this suggests mid-face deficiency. If the intercanthal distance is wide, this may reflect developmental imbalance. We also analyze the nose. The nasolabial angle is particularly important, normally between 90 and 110 degrees. Proclined incisors tend to flatten this angle, while retraction can increase it. Over-retraction, however, can make the nose appear larger than it really is, a classic aesthetic mistake. Then we examine the lips. Using Steiner's E-line, a line from the tip of the nose to the chin, the lips should rest slightly behind. If they are far ahead, it suggests protrusion. If far behind, it suggests retrusion and a flat profile. But remember, this must be interpreted by racial and cultural norms. Fuller lips are normal and attractive in many populations and should not be overcorrected toward Eurocentric standards. Finally, smile analysis. The ideal smile arc follows the curvature of the lower lip. A flat smile arc gives an aged appearance, while a consonant arc looks youthful. Buccal corridors should be balanced. Too wide and the smile looks empty, too narrow and it looks artificial. Ideal gingival display is about 1 to 2 millimeters. More than 3 millimeters produces a gummy smile. Treatment planning with soft tissue in mind. In the past, orthodontists planned treatment by starting with the teeth, achieve perfect occlusion, then check aesthetics. Today, the order is reversed. We start with the face. We ask, what profile and smile does this patient need? And then we work backwards, planning dental and skeletal changes to achieve that goal. This is called retro-engineering. Take, for example, a Class 2 patient with a retrusive mandible. One option is to camouflage with extractions and retract the incisors. Occlusion may look fine on paper, but the face will become flatter and more retrusive. Aesthetically poor. A face-first plan, instead, would use mandibular advancement, either with growth appliances in adolescents or surgery in adults, to truly improve the profile. Optimization and database planning. Another important principle is optimization. Diagnosis is not just about listing problems, it's also about recognizing positives that must be preserved. A patient may have a poor occlusion, but a very good profile. In such a case, extracting teeth to create a perfect bite may destroy lip support and harm facial aesthetics. Optimization means fixing what is wrong while protecting what is right. Problem-oriented diagnosis is key here. Write down skeletal, dental, soft tissue, functional, and aesthetic findings. Then design a plan that corrects negatives but avoids harming positives. Modern databases and digital tools now allow us to store and compare treatment plans and outcomes, which helps standardize diagnosis and improve decision-making. Conclusion. So, to conclude, orthodontics today is more than moving teeth into neat rows. It is about shaping faces, protecting aesthetics, and improving quality of life. We must look at the patient as a whole, the teeth, the bones, the soft tissues, the smile, and the psychology. Records must include not only cephalometrics and casts, but also dynamic photographs and videos. Analysis must consider vertical thirds, transverse fifths, nasal profile, lip balance, and smile arc. Planning must begin with the face, not just the occlusion. And optimization must always preserve the patient's natural beauty while correcting their problems. Always remember, numbers guide us, but the face is the final judge. Orthodontics is both science and art, and as future clinicians, you will carry the responsibility of balancing both.